Welcome to the panel. When can I say no? Ethical approaches to inappropriate care. My name is Shen Ma. I'm an assistant professor of ethics at Loma Linda University, also co-director for the Center for Christian Bioethics. Pleased to introduce our two workshop panelists here, Dr. Gina Mohr and Dr. Grace Wee, both of whom I work very closely with. Dr. Mohr is a graduate of Loma Linda University School of Medicine. She completed her residency in family medicine at LLU as well, and she's the founding director of the LLU's palliative care program and currently serves as the chair of the ethics committee. And having taught collaboratively with Dr. Mohr, I can tell you that she's famous for being a very engaging and beloved teacher who really inspires her students to think very critically about ethical issues with her deep ethical insights into very complicated clinical situations. Can you hear me? Okay. Yeah. This one died again. And next is Dr. Grace Wee. She also went to Loma Linda University School of Medicine. She completed a combined internal medicine and pediatrics residency, as well as a pediatric critical care fellowship at Loma Linda University Health, and is now co-director of the Center for Christian Bioethics, among the many hats that she wears. Working with Dr. Wee is itself a great privilege because of her moral integrity really inspires those around us to want to be better. And I know her by her ability to really think clearly about really complicated ethical dilemmas, just be able to cut through the complexity and get to the core essence of an ethical situation. So it is my pleasure to introduce to you Dr. Mohr and Dr. Wee. I'll turn the time over to you.
Thank you very much. Grace, do we need to give them instructions up front? Yes. Because we're going to have some polling questions, so we want you to get prepared.
So if you use your phones, you can text my name, Graceoei, it's not an L, so Graceoei 766. So if you text that to 22333, you'll be able to join the poll everywhere. Or if you don't have text, you can go to the website. It's pollev.com/GraceWee766. So you should be able to join now because we actually already have our polling questions open.
All right, so we'll get started. Oops, oh no, not yet. There, we'll slow down a bit. So sorry.
This just says you joined the session. When you're done, reply leave, but it hasn't taken you to a poll. Is it supposed to do that?
Yeah, so the polling question, it's active, meaning that when the question comes up, you'll be able to respond.
I see. So it'll come in on its own.
Yeah.
Okay.
Yeah, but you should have, if you've done this, then you should be able to join in. And if not, we'll have the instructions up again.
Excellent. Okay, everybody ready now? All right, so a few objectives. Grace and I really want this to be as interactive as possible, so ask questions, make comments, that's what we want to do. Unlike the philosophers, right, which I loved that definition of the difference between a steer and a philosopher. That is great. I was actually in Fort Worth a couple months ago and went to the stock exchange, right, the different stock exchange, but you see these giant steer walking down the road and these giant horns, quite impressive. So today, we want to learn how to approach cases of potentially inappropriate care. We're going to focus on CPR specifically, but it's a little broader than that. Understand the steps of the conversation depending on the patient's condition, because I would argue it's not just about the ethical principles, it's about how you get there and the conversations that evolve around these situations. And then finally, recognize empathic statements that can be helpful. So here is case one. This was an actual consult. I've changed some of the details. But this was the wording of the question that they had. They said, limitations of treatment / goals of care in vegetative patient with grim prognosis, with family refusing to see patient and make decisions for care. So just based, I always try to make inferences from just the question of the consult. So what do we know so far? Is this a happy team or a frustrated team? Pretty frustrated, right? I mean, you can read it in there. They want to limit some things. Clearly, they think that some of the things that we're doing are not appropriate. Actually, they put vegetative. I would say that was probably not an accurate statement, but we'll get into kind of the details. Grim prognosis, we often see that a lot. That kind of conveys some information to you. And family refusing to see patient. Now, I will tell you that in my younger and more my naive days, I used to be a little bit more judgier than I am now. I still am, but I was more so. And I would get really upset when there were families that seemed to never come. But there are reasons for that often that we do not know about, right? Other sick relatives, little children, working 2 jobs to keep food on the table, right? So lots of reasons why families don't come that we don't often know about. So we know a lot just from that statement or the request for the consult. So this is a 69-year-old woman. She has a history of hypertension and atrial fibrillation. And unfortunately, 6 months prior to her coming here, she was diagnosed with some sort of a polyneuropathy for which I don't know that we really know the details or understand the circumstances, but it left her essentially paralyzed. And she was actually so debilitated that she was unable to breathe on her own, so she had been put at a nursing facility. She's on a trach and vent and with a peg tube. At her baseline, she's able to interact some. She seems to understand things. She's able to, at least to some extent, maybe do eye movements. But she has had a long, pretty complicated course in the last 6 months. And she comes into us because she is septic, very, very sick. Not only is she septic, but if you kind of go through the organs that are not working, right? So she has respiratory failure. On a ventilator. And one comment about this, I'm always interested in seeing kind of how we manage these cases in the ICU. It's always interesting to me that no one is actually dying in the ICU, but what they do have is they have respiratory failure on a ventilator, right? They have renal failure on dialysis. They have cardiovascular collapse on pressors. They have hematologically, they're bleeding and they're getting transfused frequently. Their gut isn't working, so they're on TPN or total parenteral nutrition, and their liver isn't working very well, making them encephalopathic. But each of these things we can kind of tweak, right? I can tweak the ventilator. I can adjust the dialysis settings. I can figure out which electrolytes to put in the TPN. So this makes it so that I feel like I have control. Right? Because if I said, Mrs. Swan is dying, I would feel like I had no control. And that is absolutely not acceptable. Right? So we kind of delude ourselves, and we all do it, doctors, nurses, respiratory therapists, we all kind of feed into this, that we have some control. This woman is, I think, is clearly dying. But it's interesting how sometimes families can look at the same patient in the same situation and feel very differently about that. So the team, I talked to the team, and they're very frustrated. They say, you know, she should be DNR, and we've told the family they need to stop all this. We're torturing her. You'll often hear that, right? Which, again, has its own judgmental qualities associated with it. So what do you think of this team? First of all, are they right? Is that the right course? And whether you think they're right or not, is there a better way to get to where they want to be than maybe what they're thinking about? What do you think? Let's open it up for some thoughts. Anybody ever seen a case remotely like this? Yes, yes. So what do you think? What do you think? Yes.
I think the very first thing is it comes across the team has an agenda and they're emotional, right? You know, and which is understandable with human beings practicing medicine, and it's the day in, day out, and you see what's happening and how things are progressing. But that bleeds over into your communication with the family. The agenda is bleeding through the whole thing. There is no such thing as a singular conversation that's going to happen that's not going to have an agenda behind it, such as a DNR, DNI, or to impress the critical nature of the situation. And there's so much more that can be done with just establishing better rapport, relaxing the guard, and getting a sense of what the family's perspective is. Not challenging their perspective, but rather assessing that perspective. Just if that were an agenda, that would be different, but it's.
That's fantastic. Thank you for that. So very true. They definitely have an agenda, and we often see this, right? They have an agenda that may or may not be one that we agree with. Yes.
So I might be the advocate of the devil right now.
It's okay.
So on the other hand, I also hear a team that I have seen this so many times.
Yes.
That I have done CPR so many times on these patients, and that they have seen how their patients are bleeding out literally.
Yes.
So is this, well, because I kind of know how this is going to end, then can we please push a DNR so we don't do harm to this patient, right? And then I hear also the aspect of moral injury on the staff. I know clinically that this is not going anywhere. What are we doing here? That's most of the time the question I hear.
Absolutely. And there was absolutely that moral distress that was present. And so I think in ethics, we are really kind of ministering to our patients and families, but also to our healthcare teams, the staff, all of those. And so we're kind of like mediators, right? We're trying to figure out how do we engage conversation between the two when sometimes there's a difference of opinion. That's what we do, right? We deal with conflict all the time. Yes.
I think what you said is part of the challenge. You know, the healthcare professionals have seen this so many times, right? We understand medically, right? We can intellectualize what's going to happen because that's what we do, right? But families are coming from a place of the heart, right? We're coming from the mind, but families are coming from an emotional state that it takes sometimes many conversations to get to that point, if we get to that point.
Right. Thank you. That's a great point. Yes.
And just adding to what he shared, the tension in all of this is that if you're standing in a space where you're trying to give some credence to both the facts and the feelings, in the midst of that, you can be seen as irrational. So you, even as yourself, if you're a chaplain or you're giving credence to, here are the facts of the situation, but here's the heart of the situation, the feelings of the situation. And then how can we now have more dialogue so that we can understand both sides? It becomes a place of tension even for the person that is trying to navigate that.
Absolutely. Thank you for that. We often talk about, these two different levels of facts and feelings. And physicians and the healthcare team are really, really good at spouting lots and lots of facts. And doing it fast and doing it quickly and adding to those facts, right? But the family here is dealing with the feelings. And until we get to the point where we meet, and I guarantee you that the family is not going to come up here and say, okay, let's talk about the hemoglobin, right? So we really need to have our healthcare team say, let's acknowledge these emotions, because until you acknowledge those emotions, none of the facts even matter.
Yeah.
Not yet.
Faith becomes the bridge.
Yes.
So I call it the 3 F's. You have to have all 3 F's in the conversation of facts, feeling, and faith, because faith often is the bridge over to what people are feeling. And even within healthcare, people will start to say, they'll start to ask the questions around God, and immediately you see them going into their feelings. Immediately you see them asking the harder questions. And I found that that's an easier bridge when the faith is brought into that conversation.
That's a great comment. Thank you for that. Anybody else want to comment or want to lament on their own cases that they've seen and say, yeah, been there, done that? Yes, sir.
I think the thing you said about the doctors will reference the blood pressure's stable.
Yep.
Kidneys are doing good with dialysis.
Right.
TPN is giving nutrition, so the family has no reason to think this isn't working.
That's a good one.
Yeah.
We're trying to help them stay in denial, actually.
Yes, absolutely. Yes.
We often invite family members to come in and literally look at the patient in the ICU and see, look at the body, is this how your loved one would want to be? Because when they see it, they have a much different impression than when they just see it.
Absolutely.
And I think that can be a tough thing. Certainly we want families to be there, There are sometimes, for whatever reason, families who say, no, I don't want to be there or I can't be there. And then we sometimes get judgmental about, well, if you can't stand to see them like this, how do you think our nursing staff can stand to look at these wounds day in and day out, right? So a comment back here?
Oh yeah, I was just going to say, much to his point, something else that I think is a variable is on your provider team. There's varying differences of how comfortable each provider is with death, and sometimes that influences how you speak to families.
Absolutely.
Great point. Absolutely. Yes.
Yeah, I think that the case or the question as it was described in terms of the rhetoric says more about the feelings of the staff than the facts of the situation, because just the language like vegetative, what does that actually mean? Grim prognosis, we see them documenting that, but they won't document actively dying in the chart.
Right.
And so there's obviously some feelers there that are more indicative than the actual realities of what's happening.
Yes. Thank you for that. Yes, sir.
And the other thing that is important is understanding the cultural context of who the person is, right, and how they use faith or other cultural experiences, right, to come to that decision making. So unless we, validate, or acknowledge what their cultural background is and how it might be influencing their decision making, we may not be moving the needle at all. If you had put in there, I don't put race or anything or ethnicity in my, in my writing, but if you had put like this was a 60-something-year-old, black female or African-American woman, then it might shift you to thinking, okay, well, do we need to call the chaplain or think about faith, or, why are we asking someone to stop something when it's coming from a population who has been marginalized and we've wanted them not to do things. So now you're asking me to pull something away,
Yes.
at the end of life.
Right. Right. Thank you for that. Really important cultural considerations. Okay, we'll go here, there, and then over there.
We usually ask if anyone in the family had any previous conversation with the patient about these issues. Would they have wanted that? That's one of the first things we always ask.
Absolutely. So any previous conversations? Yes.
We have families say, why are we trying to take away their hope? And that they are people of faith and they believe in miracles. And that is one of the toughest things, I think, to navigate with family members.
I agree. And there was a hand over here. Yes.
I just went through it with my husband passed. I'm not saying that for pity or anything, but because I'm a part of this system, I have to applaud our system and also say from the family point of view that you cannot fix that program. Any of us that have been through it, there's no perfect way to do it. But what I found is there were times when the team could have said your husband died for a year, but they did not. But their body language began to prepare for it. But they did it in love. And so I think our subconscious starts to get it. And when it's time to kick in, it comes out. I remember being in the heart doctor's office maybe 4 months before my husband passed. And he came in and his body language said, this is not good. And my husband said, well, we're good, doctor, I'm good. And I remember looking at the nurses. The nurses had masks, but they had tears in their eyes. Though I couldn't accept it at that moment, I left with their tears in their eyes. So subconsciously, I knew my husband had died. So when it was time, I still, as a family member, was in denial. The moment my husband was literally dying, it took the doctor to scream at me. They had to get him on a phone. And he literally, at that point, yelled and said, your husband is dying. And if you don't sign this DNR, he will suffer. Because the team was already in there to start to bring him back. And I, as a family member, I couldn't get it until he yelled. At that point, he had to be ugly. He had to kind of slap me with words. And I did it. But with what they did not say, but what they did say with their body language, with their actions. That's all we can do. That's all you can do. Is whatever you do it in that act of compassion. Whatever it has to be, it's received in a way that is healing when they're.
Thank you for sharing your story. That's a hard experience to go through. So we appreciate you experiencing that. So let's move on. Oh, we're ready. So here's our first question.
So I've already been getting responses.
Oh, good.
This is going to be, unfortunately, I do not have the right adapter. My adapters are old. We've been joking that they deserve end-of-life care. So, so the poll is going on live, and I'm just going to have to tell you the results, but we're not going to be able to project the results out. But we'll give you guys just a few more seconds to go ahead and respond. Anybody not have a chance to, or having difficulty connecting? Everybody can connect? You're having difficulty connecting? Are you?
The website works.
So the name is GRACEOEI 766. I didn't want to pay for the premium membership, so that's why they gave me this this name.
And Grace,
yes.
the results show up on your screen.
Oh, the results show up on your screen. Fantastic. Wonderful. Thank you so much. All right, so we'll just give you a few more minutes before we close this. Not a few more minutes, maybe a few more seconds. Why don't we just do 10 more seconds? Right, 3, 2, 1. Okay, I'm going to go ahead and close the poll. Whoops. Okay, so I'm showing here. Oh, thank you very much. Oh, I think this might be it. I'm showing here that 9% answered yes, healthcare teams can place unilateral DNAR orders. 47% of respondents said no. 13% said I don't know, and 33% said depends. Oh, let's go on to let's do the next. Our next question. This is actually a free text, and this is wanting to get at, and you can either text in here, or if it's easier, just raise your hand and we can share. But what exactly does DNAR mean? So when we say we're going to institute a unilateral DNR, or when the team calls the clinical ethics consultant or asks for an ethics committee consultation, what do they really mean when they say we want the family to agree to a DNAR? Does that mean the other treatments must stop?
No.
Okay, she's going to try to get that connected, but anybody want to just raise their hand and say, what do we mean when we talk about do not attempt resuscitation orders anyway? Because if you look in the literature, there's actually scarily a lot of variation of opinion among physicians, which is not very reassuring. I've had people who have been in the ICU getting pressors or blood transfusions, and someone will say, well, why are we doing this? They're DNR. Right? So DNR really should mean do not attempt a resuscitation, and really that's CPR. And short of that, everything else is still on the table. But there seems to be massive confusion about that. I had a gentleman who was dying from a gastric cancer who was slowly oozing from his tumor. He'd been in the hospital for a number of weeks, got to the point where he realized that he wasn't going to survive. But he was getting transfused maybe every 2 to 3 days. So he had agreed to a do not attempt resuscitation, but he had a young child that he wanted to spend as much time with, who came in to visit. And so he wanted to continue transfusions. And there was a lot of frustration on the part of the team saying, why are we doing this? This is futile. I said, I think it's actually working really, really good. It's extending his life. Now, it might not be curing his cancer, but if that's not the goal, then it might be helping him with his goal of living longer to spend time with his child. So, do you have, I guess that, there's just yes or no, huh? Lots of no's. Anybody else want to weigh in on what they've seen with kind of the confusion over what a do not attempt resuscitation means? I also like the attempt part, because when it sounds like do not resuscitate, it sounds like if I will attempt the resuscitation, it will work. But as we know, most of the time, these resuscitations actually don't work. So yes, sometimes. There's A's, B's. So I think most people in this room probably understand that it doesn't mean stopping other treatments. I've had families who've said, I'm not going to make my mom DNR because we did that with my uncle and they really just stopped caring about him. So I don't want that to happen. So, yes.
Yeah, I think with this conversation and most conversations about treatment, it's all about goals, right?
Yes.
And we don't start goals of care conversations oftentimes till like end of life. And if we came in at every admission and every intervention and said, this is what we said our goal was at admission, does that still align with where we're at now? Then, we wouldn't be seeing CPR or withdrawing of event as the end all of care, right? It's one of many interventions that patients receive.
Right, great. Okay, I'll leave it to Grace.
Thank you. I also want to point out that although we focus on the family members wanting to explain what DNAR or DNR to family members, we are also, as those of who do ethics consults, we are also educating the medical team too. Right. I mean, if you go back to read the initial consult quote, which was, the family refuses to come in and see the patient and make decisions that they need to be DNR, sometimes the medical team themselves, they wrap up DNR and withdrawal of life-sustaining treatments. So then, what is CPR? What is CPR? So the way that I like to explain it to family members is that it's a specific intervention. It is a treatment. And just like any other treatment, it has burdens and benefits. It has indications and contraindications. And what it is, at its very core, it's a number of interventions that we do together. It's a bundle that we do together in order to attempt to restore blood circulation. So the things that we try to do together is that we try to make the heart pump or beat from the outside of the body. That's the chest compressions. So we're manually pumping the heart to eject the blood from out of the heart out into the rest of the body. And we also want to oxygenate that blood, so because the blood carries oxygen to our vital organs, so we want to be able to control the airway. So often we intubate, we put a breathing tube in, or we use a mask, we use a bag, and then we try to control the airway. And the last thing that we try to do is we give medications. And, the technical thing is that you try to increase the diastolic blood pressure so that you can perfuse oxygen to the heart muscle and restore a heart rhythm. And medically speaking, if you do external compression, but you don't control the airway, even if you're able to get blood pumping into the blood vessels of the heart, you don't have oxygen delivery to the heart muscle. Mm-hmm. So it's not effective. So chest compressions without airway, not effective. If you have manipulation of the airway without chest compressions, not effective. If you're going to have compression of the heart, you have airway, but you don't have also the medications in order to dilate the coronary blood vessels in order to have blood flow into the heart vessels, not effective. So we like to call it the trifecta, and never should the trifecta, at least in this situation, we do not recommend that the trifecta be unbundled. They need to work together. And so if you have effective CPR, if you're able to restore circulation, that buys you enough time to figure out whether what caused the cardiac arrest is reversible. So one question that family members often ask is, well, why is the default status to attempt resuscitation on everybody? Isn't it because it is good for everybody to have CPR? Well, no, not really. The default status is to attempt resuscitation because if somebody has a cardiac arrest, we don't know right offhand whether it is a reversible cause or not. Sometimes we will have good information to help us understand and have a really good idea about whether the cause, if they're going to have cardiac arrest, whether it's going to be reversible. But, you know, for a bystander, if you're out in a crowd, somebody falls over and has a cardiac arrest, we start CPR because we want to buy them enough time in order for our medical technology to see whether the cause for the cardiac arrest is reversible. So it saves the lives of those patients with reversible causes of cardiac arrest. But CPR will not treat the underlying causes of cardiac arrest like sepsis, severe infection. It's not going to treat a stroke. It's not going to treat cancer. It's not going to heal or treat heart failure. It will actually worsen the neurologic outcomes of patients with underlying disease states that can actually result in cardiac arrest. So if you have severe sepsis and septic shock, and you are progressing towards cardiac arrest, CPR may buy you some time to perhaps allow some of your other interventions to work if your interventions are going to be effective, but CPR is not going to actually treat the underlying cause. So does inpatient CPR actually work? In some cases it does. But what we want to really focus on is not just survival to discharge, but intact neurological survival. So when we talk about intact neurological survival, we talk about something called the Cerebral Performance Score, or the CPC. CPC 1 is no or mild neurologic disability. Category 2, moderate neurological disability. 3 is severe neurologic disability. 4, coma or vegetative state. And 5 is brain death. So a score of 1 is really considered the ideal. There are a number of patients or families who would be okay with a score of 2, moderate neurological disability. However, there are patients who come into the hospital already existing with a performance score of 2 or below. Or sorry, 2 or higher, meaning 2 to 5. So then the question becomes, not does CPR work, but is inpatient CPR, is it right for your patient? How do we approach it from a standpoint of your loved one? How do we look at it within the illness journey that your loved one is going through? And we want to do this from the clinician perspective, and we also want to do it from the patient or the family perspective. So it's helpful to have literature. We have a number of literature, number of articles that are available. This is something that I have rediscovered recently and thought, oh, maybe it's a little bit more helpful than I initially thought. But it's something called the GOFAR, or the Good Outcome Following Attempted Resuscitation Score. And what GOFAR does is it has you input a number of your patient's characteristics. And based on your patient's characteristics, it can help you understand how or what is the percentage of risk that your patient will actually have intact neurologic survival. So we're talking about a CPC of 1, which, again, it's a pretty high standard. So the patient variables are a number of comorbid conditions on admission. And I thought what we would do now is actually show you how to come up, or how to bring up the score, and then we can input the variables from Mrs. Swan, our patient. So Gina, I'm going to hand this back to you.
Okay. So Grace is going to go to the website where you can enter this data, and based on what we know, she is...
Hold on, let me erase this. Okay.
All right.
So
she is 69. Come on this side.
She's neurologically intact?
We'll say yes, because at baseline she's able to interact at least somewhat. She does not have trauma. She did not have a stroke. She does not have cancer. She does have sepsis. Does she have a medical non-cardiac diagnosis? Yes, that's pretty broad. She has some shock liver. She came from a nursing facility. She is hypotensive. She is on dialysis. She's on a ventilator. And I think we'll throw in pneumonia for good measure. So this is just an objective score, right, that is not perfect, but 25 points gives you a very low, less than 1% survival to discharge with good neurologic status. So not good. Now, could my Gestalt feeling have told us this? Yes. But it's kind of nice to have something maybe a little bit more objective.
Again, this is from the MedCalc, just an explanation or the interpretation of your GOFAR score. So this is survival to discharge with minimal neurologic disability. Again, a cerebral performance category of 1. I do want to point out that above average survival, in your risk group of above average survival, their survival to discharge is greater than what? 15%. So even that amount of survival is not great. So what we would suggest is that we are using the medical knowledge that we have in order to be able to ask the right questions and have very tailored discussions with our family members. We're not talking about giving up hope. We're not talking about giving up. We are talking about whether specific interventions are right for your patient, with the understanding that we all possess a certain finitude, that we need to approach this very difficult conversation with compassion. So how do we do this?
So I think this was mentioned actually earlier, but if we can have earlier conversations, right? So in the outpatient or early hospital visit, start to help people start thinking about these things, right? So things like saying, it's hard to predict how sick you might get in the future. If you got very sick and had to be in the hospital, have you thought about the type of care you would want? And I think a more important question, what are you willing to go through if you only had a small chance of getting better? If you haven't read Atul Gawande's book, Being Mortal, I'd highly recommend it. I think we come at these discussions from the wrong position. We usually will say things like, well, do you want CPR? Do you want dialysis? Do you want chemo? That's the wrong place to start. The right place to start is, what is so important for you to be able to do that makes your life worth living, right? What do you want to be able to accomplish? Is it important for you to be able to talk with those who you love? Is it important to be able to be awake and interact with your environment? If that's the case, then we can then make recommendations about that, right? So I think really focusing on what's important to you, but really, what are the trade-offs you're willing to give up to get more time? So I have people with, say, heart failure. And one of the things with heart failure is that often you then go into renal failure, right? You go into cardiorenal syndrome. So we could potentially keep you going on dialysis. Is dialysis something that's going to help you meet your goals? Is it going to give you the quality of life that you find acceptable? Some people would say dialysis, no problem, piece of cake. I go there 3 days a week. I chat with my buddies there, not a problem. Other people say dialysis, miserable. I can't imagine making someone do that, right? So it's very much based on what's important to them. So that's important to realize. Who would you want making healthcare decisions for you if you couldn't speak for yourself? This is probably even more important than what do you want? This would actually probably maybe limit the number of job opportunities ethicists have, because this is often what happens, right? A patient can't talk, family members are fighting, disagreeing about what they want. But if they had said ahead of time, listen, if I ever get sick and I can't make my own decisions, talk to my brother Bill. Then we go to Bill, and hopefully he has a sense, an idea of what this patient would want, and we get to help guide them through the process then. And have you ever talked to your family about this? I use this picture of the Grand Canyon because back in the beginning of our discussion about this patient, you know, the team really wanted to go from here. This patient is on like every life support measure known to let's stop all of them. And if you tried to traverse the Grand Canyon with one giant leap, you're probably not going to make it. But if you decide to go down the trail and go across the bottom and go across the river and go up the other side, you might make it, right? So baby steps, I think, is the way to go. So instead of trying to force families to be someplace where they're not ready to be, I think we need to go in small steps. And for me, I would like to at least start with CPR, because I think CPR is the most invasive, least effective thing we do for people. That doesn't make a lot of sense. So in the ICU, it's really helpful to use the ask, tell, ask method. So I usually start meetings with, tell me what you understand so far about your wife, your mom, your sister. Tell me what you've been told. Because sometimes there's just gaps in knowledge. But once you hear that, once you hear their story and what their understanding is, you need to then tailor kind of where you go from there. The tell part is then maybe filling in some gaps, filling in some medical information that maybe they didn't understand. I'll never forget, early on as an ethicist, I had a patient similar to this. I can't even remember what her underlying issue was, but the team was frustrated. They thought this patient was not going to make it. She was on a vent. She was on pressors. And when I talked to the daughter, it was amazing to me because I sat down and said, tell me about your mom. She told me about her. And then she said, and you know, Mom and I have had lots of conversations, and she never wanted to be on life support. And I'm thinking to myself, she's on a lot of life support right now. And so I said, well, tell me what the doctors have told you they're doing. And she said, well, she's on a machine that's giving her oxygen because she's not able to breathe very well. And she's on blood pressure medicine to keep her blood pressure up. Well, there's lots of people on oxygen and blood pressure medicine. And I thought, oh, there was this disconnect between the words that the doctors had used and what this daughter's understanding was. And when I said, you know, actually, she's on a ventilator, a machine that breathes for her. And these blood pressure medicines actually are the opposite of what you think. They're actually to bring the blood pressure up. And these are what we would consider life support measures. And she was somewhat horrified and said, well, I wish they'd told me that, and because I wouldn't want Mom to be like this. So making sure that we're using the right words that people can understand makes a big difference. So ask, tell, ask is very, very helpful. So this family actually understands that the patient is very sick, but they're hopeful that she will improve. She's been sick before. She's been in the ICU before. She'll get better. And people are praying all over the world for her to recover, right? So statements that can be helpful. And it's important that we talk with the team ahead of time about if there's a line in the sand that they can draw. So at our institution, unilateral DNARs are very few and far between, but they do happen on occasion. But a conversation such as, I hope she gets better as well. I'm very worried that most of her organs have failed and they aren't getting better. We'll continue to do everything that's helpful. If she worsens, though, we worry that CPR would be more harmful than helpful and would not recommend it. So we're actually making a recommendation. And if they then say, oh, yeah, no, we don't want Mom to go through anything more, don't do CPR, then you've kind of gotten to the point that you were hoping of a do not attempt resuscitation. And then we said, basically, if she's not getting better, we will have another meeting to update you. And the team thought this would probably be like the next day. And sure enough, it was. She quickly got worse. She has now been intubated for 3 weeks. She continues to worsen. She's on 3 pressors at this point, and her blood pressure is barely detectable. Her FiO2, so that how much oxygen she's getting from the ventilator, she's on 100%. There is nothing above that. So she's really on maximum support. So when I ask our clinicians about this, my question often is, do you think CPR will be helpful in this case, physiologically? And they all, without fail, say absolutely not. Because if you don't have oxygenated blood and you don't have a blood pressure, pounding on the chest really does not help. So this is about as close to physiologic futility as we get, although we don't like to use the F word. But this is about as close as we get to it. So the team now says, you know, we're doing there's nothing else we can add. And if she gets worse, CPR is not going to benefit her. So my question for them is, are they willing to say, we will not do CPR? And they said, yes, that's just something we don't think would be appropriate. So you meet with the family again. Unfortunately, your wife, your mom, she continues to worsen despite everything we've done for her. If her body continues to fail and she dies, CPR will not benefit her, so it will not be done. We'll continue everything that is helping. The reason I like this is because it does set limits, but it also says we are not giving up on your loved one. We are not stopping things. We are just not going to add something that does not make sense. And for me, there's a big difference there. Now, some family members may not agree with that. And again, depending on what your hospital's your institution's policy is, your state law may vary. And this may not be an unusual reaction, right? But she said she wanted everything done. She's a fighter. And I think what we need to help, again, is connecting with those feelings and tell the family, we, you, us, we have done everything we can to help her get better. Unfortunately, her body is not cooperating. Whenever I hear people talk about giving up or that mom or dad is a fighter, I absolutely agree with that. And I say sometimes, if it was just up to their mind, their spirit, their will, they would have been better like weeks ago. But it's not up to just that. It's also up to what their body does. And sometimes we don't have control of whether our body responds to these things. And I find that a very helpful thing for families because they don't like this idea of giving up or that dad's a quitter, right? So that can be a very, very helpful thing. Again, another reaction, so you're just going to let her die? Absolutely not. We're going to continue everything that's supporting her and working. But if she does die, despite all this, it means her body is too sick to survive. Right? So back to, these are just things that we don't have any control over, but we're not quitting. We wish we had better news, and we wish our treatments were working. We're so sorry your family's having to go through this. So, these conversations take practice and time, and I think the words that we use are really important. I would not pretend to say that this fixes everything and that everyone agrees with this, but I think it gives a different approach, and I think it can be very helpful. So just a couple things to respond to. Docs, we sometimes do not do very well in responding to emotion, right? We'd rather respond to a high creatinine because that's way easier. But just empathic statements, I wish things were different. This is an incredibly difficult time we find ourselves in. I can't imagine how difficult this is for you and everyone else who loves Mrs. Swan. You've been an incredible advocate for your loved one. I can see how deeply you care. Most of my families, they have done an amazing job in taking care of their loved one. And their loved one wouldn't be there if it hadn't been for them. And I think it's important for us to acknowledge that. That is often the point where there is often some breakthrough. And people think, thank you for seeing that. Thank you for seeing what an amazing job I have done. Right? Because that's important. Anger is tougher for me to respond to, but important to do. It's understandable that you'd be angry. I wish I had treatments that would help him or her get better. It's understandable that you would be angry. I can see that you care about him a great deal. So again, just kind of naming the emotion, getting it out there can be very helpful. And then finally, responding to grief. I know it's hard to have a loved one in the ICU. I want you to know that all of us here care deeply about your experience and your loved one's experience right now. So just kind of basic empathic statements to help people know that we see you, we hear you, and we actually are on your side. We would want nothing more than for your loved one to get better, because that's kind of why we went into this in the first place, right? So it's interesting to me that there often is this adversarial relationship that develops when really all of us want the same thing. I don't know if we have time to do one more, maybe one more. So that was about kind of DNAR orders. This was a second case that we got. And again, I like to write in the words that are used for the consult. 64-year-old man with end-stage renal disease, trach and peg, end-stage ALS, here for osteomyelitis of both the scalp and pelvis, poor prognosis, with surgery basically saying surgery will kill him and it is futile. Patient deteriorating, but family delaying making a decision and not coming to see the patient. Some very similar elements, right, between the two. It's interesting because as soon as I got on the phone with this person and they started talking to me, they said, I know what you're going to say. And it's true that we had this conversation. So this was the situation. This patient came from a nursing facility a month ago for sepsis because of this osteomyelitis is an infection in the bone, much, much more difficult to treat. Unless you can take that bone out, IV antibiotics typically don't cure this, so very, very serious infection. Was in the ICU and on a ventilator, but they've been weaned off. Has been on hemodialysis for about the past year and has been tolerating it adequately. So this is what I see when I come on the case. We have a question. So the question is, are surgeons allowed to decline to perform surgery? Can they say, nope, not going to do that? And why? Well, that's the next question. So I'll let you do this one first. So we won't give you a lot of time.
Yeah. Oh.
This one died again.
Does it show up, the results? Okay,
Yes.
so it's basically 100%. Everybody agrees that surgeons are allowed to decline surgery.
I can talk loud. So I guess the question is, why is it that surgeons can say, I'm not going to do surgery, but we have this idea, so the majority of you had put kind of in the first question about, can we put in a unilateral DNR? Either no, or I'm not quite sure, or it depends. And I would argue that CPR is a procedure, just like any other medical procedure, that has, like Dr. Wee said, contraindications, indications, benefits versus burdens, that we always have to weigh in light of what our patient's condition is, okay? So if surgeons are allowed to decline to offer surgery, when are they allowed to do so? What criteria do they use? How do they get to make that decision? And I guess this is a free text one, but if you want to just raise your hand and answer, you can do that as well. Sure.
So surgeons can say no when the surgical procedure itself will end the patient's life, no chance of surviving. Surgeons can do it when it will make them worse, so they're not supposed to worsen the patient's health overall.
Okay. Pretty straightforward, huh? Pretty clear cut. Yes.
But the question is, because I would think so as well, is how do you quantify that risk?
Yeah.
Versus, the benefit. And that's, kind of a curious question.
Yes.
Well, you have to survive the surgery cardiac-wise and anesthesia-wise. If you don't, then why do it?
I think the challenge is that, and you've probably all heard this from the family, you tell us Dad's going to die if we don't do anything. So we want to take that risk. Let's go for it, right? What have we got to lose? I think is often a phrase. I have a whole nother talk on that title. What do I have to lose? Because I think it's actually a tremendous amount that most people, kind of lay people, don't really realize. But I think there's a lot to lose by doing things that don't make a lot of medical sense. So yeah, we typically say, man, if this is too risky, if the risks outweigh the benefits, but again, who gets to decide that? We look at heart and lung function, right? If you're being assessed for surgery, those are kind of the two basic things that people evaluate to make sure that you're going to be a pretty good candidate to survive that surgery. Anybody else want to talk about this issue of how do surgeons get to make this decision? Yes?
If it's not indicated.
Not indicated, yeah, yeah.
As a gynecologist, there are a lot of cases of fibroids that it's small, you don't need surgery.
Okay, so just not indicated? Yes.
Yeah, I mean, I think each surgery specialty has their own association of professionalism that guides what's indicated and what's standard of care. So that would be a big part of it.
And we won't even talk about plastic surgery, right? We'll just leave that off. Comment here.
Yeah, sometimes I think, just because the surgeon said, right, I'm the higher up on the totem pole, like if people consider the surgeon at the top, right, that was my recommendation, and so we're going to abide by it.
Right, right. You know, kind of the classic case I think of is the patient with gangrene, often a 95-year-old with dementia, contracted, malnourished, and the question is, you know, do we do surgery for them or not? But very challenging when families are really trying to push for that. So this patient can intermittently communicate with eye blinks, usually at baseline, but they haven't been able to do that since they've been septic and sick, which often we see people with all kinds of changes in mental status for acute illness. And the wife and daughter would really like to focus on comfort care, and they had at least gotten to the point where the family agreed on a do not attempt resuscitation status. But the son says, I want to continue everything else. And the question that really the attending had asked about is, you know, they're not getting better, they're getting worse. And the surgeons have said that this surgery would basically probably kill them, so we don't want to do this surgery. So then can we stop dialysis, was the big thing. So what do you think about that? This kind of goes back to one of the other questions we talked about is, you know, what does a do not attempt resuscitation mean? And what kind of involved in goals of care, what kind of treatments should you be thinking about or talking about with families, right? The person who asked for this consult, they said, I already know what you're going to say. And I said, you're right. And he said, I know that even though the surgeons don't think surgery is a good idea, you're probably going to say, if they're tolerating dialysis and the family wants to continue dialysis and or the patient, then we should probably continue dialysis. And I said, you are absolutely right. So he had at least picked up some lessons, I think. But what would be your approach, right? What kind of a conversation would you then have with this family? You already know that family members disagree, and that's really hard. It's hard enough when kind of the family and the team disagree, but what about when family members amongst themselves disagree? Any approaches that you guys can think of for that you have found helpful?
I think offering families, when there's disagreement, a trial period of let's try the patient, you know, for this many days, this many weeks on this intervention, see how they do, and then we'll reassess at that point whether it's appropriate to continue.
Yes.
Give both parties what they are looking for sometimes.
That's great. A trial period. That reminds me of another case we had not that long ago. A woman who had had an elective surgery for a brain aneurysm and had a very poor outcome, had been left in essentially a persistent vegetative state. Again, trach, peg, vent, off to a facility. There was a husband and a sister. And the husband, after several months, got to the point where he said, you know, I realize she's not going to get better and she would not want to stay like this. And he was actually her power of attorney. She had actually filled out a document. The sister was very, very angry and would only refer to him as her husband. So he did not even warrant a name. So they did not want to talk to each other. The team kind of wanted to try to get everyone on the same page, and the husband kind of wanted to get the sister to at least assent to things, if not do the consenting. And the plan was really, she also was had been weaned off just on trach mask, but she was on dialysis. And so he said, no more dialysis. She said, let's continue. So they did just that, a trial period. They said, okay, we're going to continue this for another week or two. And if she gets better, great. If she's not, then we're going to stop it. We had the two of them in a room together, which they would never speak to each other, but they would speak to the ethics consultant, and then we would relay that to them. And very, very sad. I mean, the sister left the room, kind of stomped out, telling the husband, well, you just need to know that you just killed my sister. So there are some tragedies like this. There are some cases that it does not matter the words you use, that you cannot fix these broken relationships that have been going on for probably years and years, if not decades. And again, in my younger, more naive days, I used to think that if I just said the right thing, I would get everyone to come together and hold hands and sing Kumbaya, and it would be this beautiful, like, Hallmark card picture. And then I realized, oh, that does not happen. Does not happen. And that in moments of stress like this, those tensions just escalate and break down even further. So, so back to this patient. So I would have said, let's continue dialysis for as long as she tolerates it. How about we talk about other things? So she was a do not attempt resuscitation, which was really about CPR. But if she went into respiratory failure again, do we send her back to the ICU to go back on the ventilator? Those were kind of the discussions I thought that could be had. So again, continuing those things that are helpful and that they're tolerating, not adding unhelpful things, and then maybe talking about some time-limited trials of things. And before we could really even go much further, she quickly deteriorated on her own and died. So I want to leave you with this. The most helpful phrases that I have found to have conversations are what I call the 3 W's. I wish, I worry, I wonder. So often what happens in conversations that I hear other teams have is, your dad's CT, it's worse, the cancer's everywhere. Oncology says there's no more chemo. We think they should be DNR and go on hospice. And for some, that might work, but not in the majority of cases. The reaction often is, what's your reaction to what I just said to you? Do you have a reaction? If you were the family.
No, I would accept it.
Okay, well, then you're an exception to the rule. Most families would say, who are you to tell me what to do? This isn't your dad, right? So instead of just that kind of very straightforward, maybe unempathetic conversation, I wish, I worry, I wonder. So instead it is, Jay, I wish I had better news for you. I wish I had better things that could get your brother better. But I'm worried that this is the 3rd time he's in the hospital in the last month. And I wonder if it'd be okay if we talk about a plan for if we can't get him better. So I wish, I worry, I wonder does a few things. I wish says, I'm wishing the same thing that you're wishing. I want to get your loved one better. But I'm worried that I might not be able to. So the reality is, even though I wish for that, that might not happen. And quite frankly, I would not be worried if I didn't care about your loved one, but I do care about him. And I'm worried that we're maybe going to do things that aren't going to be helpful. I wonder asks permission. I wonder if we can talk about a plan if things don't go the way we'd like. So I'm still hoping for plan A, that your loved one will get better, but I wonder if it's okay to talk about a plan B if that doesn't happen. So plan A and plan B is really helpful because, again, many people do not want to give up that hope, right? We're talking about hope here of their loved one doing well, right, and coming home with them. But if that plan doesn't materialize, then we kind of have a backup plan, but they haven't given up plan A. And I've found that that is a lot easier, I think, for families to swallow than just being told, nope, that's not a possibility, and now we have to make a plan for this. So I wish, I worry, I wonder have been very helpful for me, and maybe some of you have used it as well. We're going to leave you with some resources here. CAPC.org. CAPC is a Center to Advance Palliative Care. They're a great resource. Vitaltalk.org is fantastic for having all kinds of conversations, lots of different tips and tools there. And Ariadne Labs was where Atul Gawande was working on a serious illness conversation project. So we've got a few minutes for questions or comments. I'm going to give this over to Grace and see what questions we have.
Yes.
I appreciate the tools. If I were to say that I'm not going to do CPR, I and a lot of my colleagues worry about our legal liability, and would the hospital support us with all the tools that we've used, with all the creatinine plunging, liver failure, heart not responding to pressors, at a high FiO2. Is the agency, is the hospital going to support the doc in saying it's time to not continue
this kind of work. I agree that we need to be compassionate, but bottom line is a lot of us will continue doing things to avoid those conversations and to avoid risk.
I really appreciate your question. And, for those of us, just to reemphasize, the question is, okay, I can say no CPR, but will my colleagues also say no CPR? And also, will the hospital administration back me up if there's going to be pushback against whether CPR is going to be offered or not? So I'm going to say a couple things to that. The first is that one of the most difficult questions, really, when I'm hearing you asking, is that this question of whether to provide CPR is not only a patient-physician specific question. It also gets to a more the social context of what saying no to a specific treatment means, and what that means for the hospital. And yes, administration should be involved in these types of conversations. So what are appropriate channels? A guideline? A policy? What are the state laws? I think it's helpful to know the state laws in which you practice. I'm just going to speak for California, which is where we practice. California law says that ineffective treatment does not need to be offered. It is in the California Health Law Decisions Act. It does not need to be offered. And this has been longstanding law. I mean, this is not a change recently. However, I find, and Gina, you probably found this too, that any mention of I am going to sue you tends to be used as a threat. So what I have personally done, because I'm an ICU doc and I have heard this, I respond to the anger that question is as a response to. And I say, I'm sorry to hear that. And you are welcome to obviously seek a second opinion and to seek legal support. This is a recommendation that I'm making based on my medical expertise. But it's always a good idea, I think, to look at or to speak with your administration and your leadership to see whether a guideline would actually be helpful. Over COVID, during the midst of COVID, we actually came up with a guideline. We talked about having a guideline for exactly this. Okay, I'm not going to be able to find it in here. Let me just hand this to you, and then let me pull up the guideline.
So my mentor in ethics, Bob Orr, taught me something that's been very helpful. So often when we're doing ethics consults, we'll get asked, hey, can I get sued if? And I always say, stop. The answer is the same. Yes. Yes, you can. But that's not the right question to ask, right? The question to ask is, what's the right thing to do? What's good medicine? And if you spend more time in focusing on that, you're actually less likely to get sued. The folks who are more likely to get sued are those who are worried about getting sued. So again, focusing on what's the right thing to do, practice good medicine. Our attorneys, our legal counsel has said, that's correct, that's what we want you to do, and then if you do the right thing and practice good medicine, we'll support you.
So this is a memo that we distributed out through clinical ethics collaboration with critical care leadership. And this gets to whether CPR can or should be offered, or actually can be not recommended or not even offered. And the point of this is to reduce practice variation so that if I'm on service and I'm saying no, my colleague is not feeling the pressure to then say yes, which then I think undermines the credibility of the entire group. And so the recommendation is saying that CPR does not need to be offered or provided when it is physiologically futile, or when you have an irreversible medical condition in which imminent death is expected. It goes on to say that if the treatment goal is unclear, it is ethically permissible to provide CPR to be reevaluated at a later time. So this is essentially a time-limited trial of therapy. What is interesting is that we tend to focus on the DNAR. And so sometimes when a patient, we've worked with the family, and the family has agreed to do not resuscitation, but all of the other treatments have improved, the patient actually doesn't die. The patient actually improves. And that is because whether a patient lives or dies or whatnot is not dependent on that DNAR order. But sometimes it's hard to get out of that mindset. And the third recommendation is to ask for a clinical ethics consult. So we always ask for our teams to have a very low threshold to give us a call, especially for these difficult situations. Yes?
Yeah, I wanted to mention that going off of this excellent conversation, and thank you for the presentation, like over this last year of the pandemic, my hospital system went through a unilateral DNR pathway process that wasn't policy, but it was a protocol for our physicians. And it was Ohio has very strict guidelines on withholding, withdrawing, life-sustaining interventions. But I think that one of the things I have found helpful, and it takes a special kind of hospital to do, and it's not present in most hospitals, I'd say, but to have our legal team actually have like boots on the ground at times in the education around this with ethics is so helpful to our providers, because I think our legal team often feel like these people upstairs that nobody has access to, and there's these questions, right, of legality that I'm not an attorney, I'm not going to, answer. I can't answer a legal question, but the collaboration between the two around these kinds of things is so helpful for our staff and the distress and things like that.
Yeah, thank you. I couldn't agree more.
We have often more distress when the providers cannot agree on a treatment goal. Like surgeons in cancer treatment or otherwise, and the family is zeroing in on one provider. We sometimes wait until one surgeon is out of rotation for the next one, and so the patient can then maybe die. If you offer something, you have high moral distress on the staff who may not agree with the surgeon and his way. So that is one of the part that we have to deal with.
Oh boy. What happens when the staff,
I don't know if it ever happens to you guys, but it happens to us.
It never happens to us. I'll just tell you a story of personal experience of a very, very, very difficult case. And this was the case of whether this 18-month-old child should be given a heart transplant, and to what degree we would go through in order to separate the child from the only loving home they had known, put him in foster care, and in order to try to get the patient to a heart transplant. And so there was a lot of moral distress because reasonable people came to very different conclusions about what was an appropriate amount of burden to impose on a child. And I think to this day, right, when I still work with some of the colleagues from that team, and I still have conversations with them. And one of the things that I have come to the conclusion is that we have to have compassion. I'm saying this to myself, not just to, I'm saying to remind myself, we have to have compassion for each other and to have compassion for ourselves and have compassion as well as for our patients. And we have to accept that reasonable people can come to reasonable different conclusions and to be able to support each other through that. Because if we are all trying to do our best, what more can we ask of our colleagues? What more can we ask of ourselves? And maybe in the future we will come up with, some new information that can help us to make these difficult decisions.
We had one case where one physician called the other murderer if they wouldn't go through on a pediatric case. It was at surgery, so it got pretty heated and very, very intense, and we were all involved. Yeah.
I believe that the conversation got very intense. I believe that. Yes.
I have one question that probably many of you had some similar situation. What will be the ethical perspective, not the legal perspective, but ethical perspective? For example, when the patient decide to do not resuscitate, don't do the CPR, get unresponsive and code blue, then the team is coming to provide the CPR. We have the order to do not resuscitate, but husband or like wife is telling, no, you have to do. I am power of attorney, you have to do it.
So what happens when the surrogate, the power of attorney, the person who's supposed to make decisions for the patient, makes a decision that is actually what the patient would not have wanted? Yes, this gets very tricky, and hopefully it's not right at the moment of CPR, but sometimes that does happen. We always recommend that the team and the surrogate is guided with what the patient would want. And, honestly, it's really hard to make a decision about what your loved one would want. I've been married for over 20 years, and I can't actually tell you what my husband would want to eat for dinner tonight. But I could tell you a range of choices that he would be very happy to eat. So you want to encourage the surrogate and the loved one to make a decision that is consistent with what the patient would want. And often when we take the focus away from a specific decision towards values that feel authentic to the patient, that can make the decision process much easier. Thank you. And then one last thing too is I've done this, and I really try not to do this anymore, something that I find is not helpful is when the team will say to the surrogate, do you want your loved one to suffer? Well, of course not. Who wants their loved one to suffer, But that also takes the focus away from the patient and puts it on the surrogate. And that puts the surrogate on the defensive. So what we like to do is then take it back to the patient. What feels consistent with what your mother would have wanted? What feels consistent with her values? Let's focus on that, and then let that guide our decision. And hopefully that's going to prevent a lot of the you must do CPR now. But if you've been pretty diligent in knowing what the patient would want, perhaps a surrogate is speaking out of an emotion and is asking for something that the patient doesn't want, then it would be appropriate to say, this is really tough. This is really hard. But that is not in our conversation, what your wife would have wanted. That's not consistent with what she would have wanted. And it's appropriate to then say, let's find another way to be with her during this time.